That is an honor.
Yeah, you're welcome.
Thank you.
So, Matt, will you introduce yourself to our loyal fans?
Matt Swanson, co-founder and CEO of Reciprocity Hub.
Yeah, great. So, and then Lisa Berry. We never introduced ourselves. Kat McDevitt. We're the best.
Lisa Berry and Kat McDevitt.
Yeah, that's all we need.
Or
So,
Kat McDevitt and Lisa Berry, depending on your perspective. Which I think you should do it that way.
well, I think
She's the boss.
it does depend on the
Boss of the show.
But you're the smart. You're the
True,
talent.
but
You're the
thank
talent.
you.
I'm the talent. Okay, so Word Health, like it kind of just started. Yesterday
Yes.
there were some sessions. You got up at 2 a.m. this morning.
Not on purpose.
Got it. So you like flew here.
Yeah, no,
Amazing.
East Coast time. Eyes just shot open at 2:30
You're
a.m.
doing great.
Could not deal with it.
Okay.
So I just
You know,
got
I
to start
don't
doing
have that problem. I'm also East Coast time. I slept till 7 o'clock.
This is one
it.
of
That's
the times.
impressive.
This
I
is
don't
one
know
of
how
the
you
times
pulled
when
that up.
all you people on the East Coast come to the West Coast. It's great because I'm on my own time.
Yeah.
So I
We all crap out a little earlier.
Yeah.
But, so I met Matt through Startup Health.
That's
We were
right.
doing, Chris Plump and I were doing a little Medicaid startup show. And then he LinkedIn messaged me and was like, hey, do you want to hear about my stuff?
You were talking about solving like half of the stuff that I was grappling with at the
Here
time.
we
So,
are.
yeah, it was great.
hold the mic. Okay. Hold the mic.
We'll pass the mic.
So tell us about reciprocity. Like, this is a really cool concept.
Yeah, so we basically build financial incentive programs for Medicaid clinical care that is struggling with adoption and adherence. So we have all these amazing clinical innovations, care delivery programs, care journeys that are there and available for the Medicaid population. And they have proven evidence-based outcomes, deliver cost savings, everything you'd want, but they have a 3% adoption rate on their target population. And so we come in and we try to double, triple, quadruple that so that they can actually perform and deliver what they were built to do. Because the ROI that they're built on is not built at a 3% adoption rate. So they're struggling. And the problem is that you don't really want your clinical care to be experts in awareness, engagement, outreach, all of that. You want them to be excellent at clinical care.
It's maybe just unlikely they will be experts at all those things.
Yeah, there are a few that are doing it
Maybe a
well,
few.
and kudos to them. But by and large, most of these digital therapeutics, remote monitoring programs, whatever it might be, they just don't come with a pre-baked engagement strategy. And so we come in as a specialized partner and accelerate the performance of those programs.
So what are the reasons? Because we hear this a lot.
Like, you know, there's all these health plan programs aren't adopted. Like the whole wellness trend, like didn't happen because like 4 people used it, including my mother. But so what are the reasons that there is only a 3% engagement when there's like good things?
So outreach and awareness is the first phase. It's really difficult to do, especially with the Medicaid population. So you need to be really innovative about how you do that. It can't just be digital outreach. Hey, we send all these emails and, you know, it needs to go way deeper than that. So awareness and outreach, but then also having a persistent touch point with a digital platform that we have, an easy roadmap to follow, and then follow through with the cornerstone of what we do is financial incentives. So that sort of draws people towards their care. And CMS did an amazing study. They published it in 2017, 500 pages that talked about
500 pages.
500 pages. Yeah,
That
my
sounds
co-founder John Silva and I are the only ones who actually read all 500 pages. I'm
Sounds
sure.
like a CMS report.
Yeah, exactly. But that's kind of our Bible. And what it said was, when designed well, these incentive programs really work.
Yeah.
But it's rare that they can be designed well because they're really sophisticated, very complex, very hard. And so we built a company that could embrace that complexity and be that specialized partner for health systems and health plans. And without us, what you've seen is just the adoption of the very light, very weak $25 Amazon gift card to go to your primary care once a year, that sort of thing.
Yeah.
We build
CVS
programs.
gives me $20 for getting a flu vaccine.
Exactly.
So, you know.
Okay. There are a couple other ones out there. But we build programs, hundreds of dollars, to stay engaged in a diabetes management program for 12 months.
Yeah.
And you do it $20 at a time,
Yeah.
all sorts of different activities to check in, or a high-risk maternal health program, or you name it. We've built a platform that can really drive adherence to any clinical delivery program. We're not a clinical provider. We're an accelerant of other people's programs.
So you mentioned, you know, how difficult it is to engage patients, especially Medicaid members. what are the things that work beyond sending endless untargeted emails? Weirdly, doesn't work very well.
So there are a couple things. We have something that is sort of a friendlier on-ramp, a digital outreach and app that is a clarified, easy roadmap for people to follow. So having something that's more inviting as opposed to like a diabetes management program, it's complicated, it's overwhelming, it's intimidating, and there's a lot of mistrust already in the Medicaid community. So you create an easier on-ramp, something easier for them to follow. You do it in their native tongue. So the platform can switch into native language. And then you have a very diverse outreach strategy that, we do all the omnichannel messaging, but we also do direct mail. We have outbound calling. And then we have what we call the on-the-ground playbook, which is partnerships with community organizations that are out there and have those trusted relationships already. And what we do is we've got, for preventive care, maybe a HEDIS gap closures program. Many of the families that we're reaching out to have already done many of the things on their personal checklist. And so when we meet them, they already have $100 waiting for them. So the community organizations, they love being our partner because they're like Santa Claus.
They're handing out money.
They're handing out money. Exactly. So they want to help. And so we enable that by giving them the tools for registration and letting it sort of an extension of what we do on the ground.
Yeah.
So what's actually the secret sauce? Do you think it's your on the ground community people? Do you think it's the fact that you're just handing out like actual cash as opposed to like the gift cards? Like, what is it?
It's an orchestra of different things. So when we have a behavioral economics team that designs everything, tailors it to the specific program we're accelerating. So first thing we do is we take that program, they break it into an easy to understand curriculum. And so there's sort of three pillars to what they build. First is clarification. Some people say gamification, but I always think of confetti and balloons from that. So I don't really buy that. Yeah. So
It's not a game, it's your health.
what we do is we just break it into easy steps. So breaking it out into these are the next 3 steps on a very long journey, but here are the first 3 steps in front of you. In your native tongue and with all that outreach, the clarification is a huge hurdle that you need to cover. Then we go to motivation, which is the reward design. And so that behavioral economics team has the latitude within the platform to use the entire tool chest on behavioral economics. And the reward levels aren't the only thing you want to play with. There's the design, the framing, the communication. So they build for that. And then the last piece is facilitation. So in that roadmap, when you see that getting a lab screen is step 2 for $20, you click on it and you can actually pull up where are the LabCorps near me and then go right into their portal to set up that appointment. And then where we can, we actually have tools built into the app. Let's say step 3 is an SUH screen. Get $20. Well, you can take that SUH screen right there on the phone. And when you hit submit, you get $20 loaded onto that card for you in real time. And that builds a lot of trust and confidence and momentum.
You're not waiting in the mail.
Yeah. So what you build is a new relationship with the Medicaid member where they have a persistent reloadable reward card with their name on it that's in their wallet. And they think, oh, wow, I wonder if there's something else I can earn. Then they have the app where they can go and they see that roadmap. They see how much is on the card, how much they've gotten, and what the new reward opportunities are. So it's this very different dynamic with the Medicaid member where they're constantly in touch and updating their data and all sorts of
It
things.
sounds like you're reducing the time from doing something to getting something, which any clinicians will probably say, if only CMS would do the same thing for me. If only I'd have to wait for 2 years from submitting a quality measure and maybe getting a positive small payment adjustment. But that reduction of time is very, like you said, sort of behavioral economics truism, right? Like, don't make me wait a month, a year, 2 years to get some kind of positive feedback.
Well, we talk a lot about stealing the mic. We talk a lot about removing friction, right? That's really what this is, right? And it's because like if you listen to what you're saying, it's like, oh yeah, like duh, like that makes sense.
Right?
But it's all these like little things that really stop people from making a difference. Like I'm not gonna. If someone says, "Kat, we will give you $700 to go get your blood pressure taken at a CVS," click this button. It will come in the mail and you will have to register. And I'm like, no, like, I just won't do it.
Yeah. If someone would give me right now, like at the point of making an appointment or whatever, just going in, even like $20 to go get my very overdue cholesterol test done, probably would do it.
Yeah.
and I'm gonna do it anyway, but it's gonna take me a while because I'm not prioritizing
And
it.
you want to build on prior experience too.
Yeah.
So I mean, it all builds on itself.
Yeah.
So now our program with Highmark and their Medicaid population, we're now in the 3rd year.
Yeah.
So now we have people who are calling us and saying, when are the new rewards getting released? And they're waiting. So
That's cool.
we have completely changed their posture towards healthcare,
All right.
which is really cool. And then when you have these big programs that are out there, you can start layering in all these other programs that just
Yeah.
pop up on their phone and say, guess what? We just saw you're at the hospital.
Yeah.
Upon discharge, if you follow these instructions in the first 3 weeks after discharge, you get another $75. And so when people get eligibility changes around maternal health or whatever it might be, we just layer in those reward programs and people are there waiting and ready. So
Yeah.
it changes the face of engagement entirely for that population.
Totally.
So, like, what stage are you at in terms of working? You just mentioned Highmark. Like, where are you in terms of working with different partners?
Yeah, we've been really intentional about exploring different verticals. So
Yeah.
we're working with West Virginia Health Right, big FQHC, and working with them on many different conditions. MedStar in DC, Can Community on some HIV prevention. So a lot of very diverse programs, which stretches us in terms of rewarding different clinical care journeys, but then also different verticals. So providers, big health systems that are looking at perioperative care, small FQHCs, community-based programs, payers, MCOs, they're sort of given. We're going to start dipping into MA. We have our first DSNP population launching. So we're trying to test out all these different verticals because one of the other things that we do as a managed service, we manage the entire campaign. And the front end of that is making sure that we are well within the regulatory landscape that differs between each of those verticals.
Totally.
Yeah.
Right? Yeah.
So we have an expertise there that allows us to lean in and kind of help them design a program that is like, land people
Yeah.
in
Easy
trouble.
to get in trouble for that. Certainly a tricky area. You're probably learning all about the particular programs and how fantastic they are. Yeah.
So with that, why did you pick Medicaid? Because Medicaid's hard. Why didn't you go after like the commercially insured?
I know. Well, financial incentives for those wellness programs at companies are pretty prevalent. It's a crowded space. It's sort of an employee benefit type program. No interest in that. Condition-specific populations in the employer-based world, that gets interesting. And we're actually launching our first large employer,
Nice.
a state employee group in January for a diabetes management program, which is cool. The reason we started with Medicaid was very strategic. We knew if we could crack that nut and showcase, evidence of performance there, that we can move into these other markets pretty easily with those proof points behind us. So it's also, when you're working with an employee base, communicating with them is really easy. We wanted to sort of develop that muscle memory on these OTG, on the ground playbook, all this other stuff that is necessary in that specialized community. So a lot of stuff that built hurdles for us early on. When you clear those hurdles, you kind of have that toolkit to go forward. So
Yeah.
Doing the hard things.
Yeah.
trying.
What I would say to that is that, like, a state employee group is a great example of, yes, easy to reach employees, but a state employs people from like janitors to office workers to, so it's a little more like the population you're already reaching.
Exactly.
And then the other thought I have about the employee base, which, obviously we're sitting here at Health, this massive,
Lots of employer.
lots of people want to sell employers here. The problem, of course, is that employees, us, are increasingly having to act like cash patients anyway, without the benefits of being cash patients. Like, we can't negotiate, but we still have to pay out of pocket. $6,000, $12,000, whatever, and so you can see that it's almost like the employer market is moving towards you and moving towards what you're already offering.
It's true. And those dynamics, and our behavioral economics team is amazing. The mindset of the individual coming into it is the big piece of this. And so trying to get around understanding what people's deductibles are and all this, that's a whole different mindset. And moving the needle, what level of rewards are going to move employees at Goldman Sachs to behave better in health? Probably not worth it.
Maybe more, but also you never know. People have interesting sort of internal gauges of what is affordable to
So
them.
we're really interested to see what happens with this employer-based group, but we really think that one of the things that sort of mission-driven is addressing cost in Medicaid and Medicare.
Yeah,
right?
love it.
And we were built for that, and it quite frankly was what our prospective initial payer partners were saying to us. It's like, that's where we really need to focus. Nothing is being done there, and that's where we think we can move the needle.
That's awesome. That's awesome. Very cool.
So,
Kevin, Kevin.
so just tell us, because I know you read a 500-page paper to make this company, but like, why else?
Why else did we start it?
Yeah.
Yes.
So
Like, what was the journey?
it was actually a sort of a provider-led narrative that led us here. So I was lucky enough to lead some CMS-funded work in the state of Delaware, where I'm from. They did statewide innovation model grants back in the day. And so I chaired the group that received that grant and put this entire effort into place to drive a transformation from fee-for-service to value-based care. And I had small practices and systems coming to me and saying, okay, we understand this inevitable evolution towards value-based care, but we think it's really unfair that we're now taking on risk when what you don't realize is that I can do everything right when the patient is within my four walls, but the minute they leave, I lose all control. And that bothered me. There was no answer to that. And so I was like, yeah, we're all in this path together. Let's lock arms. And they were coming to me with a very fundamental issue with that. So that's got my mind thinking about, okay, how do we, in the value-based payment models, how do we start to bring the patient stakeholder group into the conversation? And I was thinking that, so I was not in healthcare before this. This is 2012. The governor asked me to lead this because I was a novice, right? He wanted somebody who didn't have payer background, didn't have health system background. I came in and sort of played referee between these two groups. But I was looking at it and saying, well, payers are paying financial incentives to health systems to behave differently, right? To take cost into consideration. And that's a major change. So why can't I convince payers to also pay financial incentives to this other stakeholder group and get them to change their behavior? And so it was sort of trying to piece together this holistic approach that can support value-based care overall. And financial incentives, that's the CMS proof, do work. You just need to build the proper ROI model behind it. So whether it's a payer or an at-risk provider, they can see that, okay, funding hundreds of thousands of dollars in rewards will actually pay off millions of dollars down the line. And so we build those models for every single program we do. And you know, hopefully it starts getting adopted more and getting more people involved in their care.
That's awesome. I love it. Very cool. Thank you so much for coming on the show.
First one out.
First
So,
one out.
Love it.
Welcome. Thank you. And you guys are finalists for the Digital Health Awards. What's the situation there? Show your
Show our loyal fans.
check it
The
out.
hardware
Reciprocity
right there.
Health. There we go.
We find out at 1 o'clock.
All right. We'll know more at 1 o'clock.
Yeah.
Oh my gosh.
We're crossing our fingers for you. Yeah. I think I was a judge, so I don't know.
Oh,
It's
that's
too
how
late.
it happens.
It's too late to bribe me now.
It's like us or
I didn't get distracted. I may not have voted at the end. So
Thank you for
Thank
all
you
your
so much.
support.
Appreciate it. Thanks for coming.
Great being with you guys.
All right. We have a repeat guest of the show.
another guy.
We are still live. We don't go off the air. We're just live the whole time. You gotta take off your nerd guys. You don't have to, but you
Keep it
know.
on if you want.
No, I hate wearing it.
Hello.
Hello.
The show.
Friend of the pod.
Friend of the pod. Friend of the
Love to
pod.
see you.
Friend of
Love
the
to
pod.
see you.
Okay.
Here,
So
another week, another conference.
I know.
yes. So
Why
we,
is healthcare so expensive? Oh, because of all of this.
But we're not because we're so poor and so cheap. We only have one mic. So speak
Yeah,
up, Mike.
one mic. I love
You gotta
one
hear
mic.
us talking about
Give me this.
Introduce yourself, Michael.
Yeah.
UC, President and CEO of Arcadia, the best data platform in healthcare.
Not worried about branding. He's like, we're
One of the 12 followers of the
oh,
show.
yeah, one of the 12 followers of the show. Yeah, yeah.
It's good to know.
And
So
maybe a sponsor. You play your
Maybe.
cards
Oh,
right.
I mean, we only have one mic. So if we can get two additional mics, that'd be amazing.
So like a
we would
$30 sponsorship.
No, Melissa some wine. Melissa needs some wine is really the bottom line.
Okay. The secret though is like private equity funds this conference. There is copious wine. I was at a happy hour, I think last year, where there was like 100 pounds of caviar
Oh yeah, yeah, yeah.
and
Yeah, yeah, yeah.
a
You look
dirty,
amazing.
oh my God, a dirty martini fountain.
Where's that party?
I don't think
Can-
we got invited.
Can we just acknowledge that like we have reached full Silicon Valley with like Busta Rhymes? Are you joking?
Okay, that is yeah.
I also like don't want to go to a Busta Rhymes conference with all of my colleagues. Like I just
I'm good.
I'm not
I'm
I'm
good.
not
I'm
go- I'm
good.
good.
I'm good. I'm good.
Yeah.
I think, we're here and that's great, but it's a little bit, every year it gets a little bit more absurd, right?
It is like a clown show.
I mean, like rumor on the street is like health is for sale because it's like it's a business,
This is some gossip.
Venture funding.
100%.
That was like a thing.
But for what? But for what? What? Okay.
I mean, Hims got acquired by Informa.
Yeah.
You wouldn't even call me an investor. No one should call me an investor. At the same time, I understand the basic principles of investing, which is that if you put money in, you want more money by like a lot of multiple. You know a lot about investing in things and acquiring things. Tell us about how business works. Tell us how business works.
Tell us how business works.
We're leaving my carbon footprint out of this conversation.
How does business work?
Well, fundamentally, business should like generate revenue and profit. The problem with the last 10 years, that profit part was really complex, and HCIT still complex. We're gonna say it's a sticky wicket, and
My
theoretically,
least favorite phrase.
what you don't
My
like?
least favorite
Oh,
phrase.
really?
A
Why?
sticky wicket.
I mean, it's better than moist, like moist wicket.
Listen,
Prison.
Let's talk about moist. I actually read a really great article about women's health and how moist women are reclaiming the narrative around the word moist. So, fellow loyal fans, moist is no longer a bad word. It's a feminine, empowering word.
I think of moist like Singapore in July, like where there's just nothing is dry.
Human.
To be dry is human.
Yeah.
You know?
Well, speaking of dry, we're in Las Vegas and it's very dry here. It's not good for my skin. Anyway.
No, I know. I was like lathering on the moisturizer this morning and sunscreen, SPF, very important. Very
So if
important.
you were going to
Are you
create a
in on-
conference, you
Okay.
would create health and you would invest, venture
No,
money
no,
into this?
I don't.
I don't.
I mean, my question, and as someone who spends too much time at conferences, that's a plug to my board who tells me I spend too much time at conferences. Can we actually change healthcare if we're all coming to conferences every week?
Yeah.
I mean, what has it been 3 in 3 weeks? I've seen you guys basically every week. I've seen you more than my management team.
We are now the management team of Arcadia.
Yeah, here we are.
We have very bad advice.
So when those boards seat open up, we'll just sit in them, scooch
Sit
right
in
in.
them, scoot in.
Scooch in.
Okay, more seriously, what are you excited about seeing this week?
Here's what I'm not excited about seeing that I know we're going to see a lot of. We're going to see Busta Rhymes. We're going to see Halle Berry. Did she already speak?
I don't know.
We don't
I heard
know.
Lance Bass is playing.
Yeah, well, yeah, I think he was yesterday. So maybe again, I'm not going to any of that.
paid sponsor. He's a paid speaker for Dexcom.
Yeah.
he
So
was
health didn't pay him allegedly, but he is in fact paid. That's unconfirmed. That's rumors. So this is what I'm not excited about. We're going to hear a lot about GLP-1s and AI.
Okay.
And that's it.
The end. So
Okay.
so,
Already heard a lot of
but where
Straw poll, what's your opinion on GLP-1?
Do you really wanna know?
We have different opinions.
Okay, yeah.
okay. So here's my opinion on GLP-1s. So I do think they can be life-saving for people who need them. My concern with GLP-1s is that they are following the exact same playbook as the opioid manufacturers, right?
And
Like,
statins before that.
well, yeah, statins. Like, I feel like maybe this is are they not like kind of relatively benign, just money making things?
Well, a lot
I
of
mean,
people think
I'm gonna-
statins are good.
I mean,
I-
good.
statins
There's not a
are-
lot of downside.
I mean, have you seen
What's the
the
downside?
improvement in cardiac outcomes for the last 2 decades? That's statins.
Could be a lot of
I
things.
fundamentally,
Could be a lot of things.
I fundamentally disagree
Loyal
with your
watchers,
perspective.
he is
Well,
sarcastic.
no, I think GLP-1s are being
I'm not being
pushed. Like they're
sarcastic.
basically pill
There's
mills,
been that, like real measured improvement.
and you can directly correlate it to statins.
Well, you can't directly.
That's
you
what I'm
can't-
talking about.
You can't.
Cat math. This is cat math.
But I think
Directly
it's
correlate.
very difficult to put opioids, statins, and GLP-1s.
Well, I'm not putting statins in the same category. I'm putting GLP-1s in the same category as opioids.
But GLPs are not addictive.
They're not addictive, but they're being pushed, financial, totally motivated for the wrong reasons. There are pill mills all over the country giving people these we have a compounded pharmacy guy coming on next, so I'm gonna just say this
Oh, yeah.
it's
No, let's just-
Oh,
let's
we
just
don't?
maybe
Oh,
the-
we-
maybe the
we
authority
don't.
figure.
we don't. Okay.
No.
Anyway. Well, I don't really know, but anyway. Yeah. So anyway, the point is, I think it's like over aggressive. I think we're putting lots of people on something that isn't proven, a lifelong drug. A lot of people are taking it that aren't necessarily reaching the threshold to take these drugs.
What drug is that not the case for? Look at the number of people who are on Xanax.
Birth control.
You need to move.
We need to move the mic. Wait, what about it? I need to hold the mic and not let them fight over me. Got
Okay,
it.
I will buy you another mic.
No, we tried. It doesn't work. We also need tech support. We have problems. Okay, fine. Okay, here's my perspective on GLP-1s. Ready? I think that GLP-1s are a really, really, really important innovation, an actual innovation, real scientific innovation. I think they really, really help people. I hate it when people say there's no evidence. It's only been around for. It's not true. The actual class of drug has been around for more than a decade. Like those things take a long time to make it through the process. Is there evidence for safety in children? Great question. I don't know the answer to that. But also, I agree with you. It's not addictive. And it's really, really important. And by the way, we have no other plan besides, we should fix our food system. Great plan. Get started. What are we going to do?
It is a great plan.
Yeah, sure. Great plan with what?
Well, it's not a great
No
plan.
motivation, no
plan.
money.
It's a
Great.
great idea.
Great
It's
idea.
a great idea. So
Sure.
I'm
we
with
should
you.
fix the food system. I agree.
Plus one, Lisa Berry.
That's right.
I'm very open. I lost 100 pounds on GLP-1. What? Yeah, in like
Nice.
2 years. 100%. Went
See?
almost completely vegetarian on it. It helped me completely find different ways to channel my stress. I drink less. I gamble less. Take less Xanax. I think we're scratching the surface of how GLP-1 receptor impacts
It
our-
impacts other types of behaviors.
As a matter,
Yeah.
I walked like craps last night.
I just have
normally.
I have
No,
whatever
I'm
that natural
so
thing is because I
drawn
don't
into it.
Wow. I am not like for whatever it is I never got that. Whatever that is, I just don't have it. I eat plenty of food, but I don't have any interest in gambling. I like to drink wine too, but I don't want to gamble.
I used
I
to
don't know
be like, put a drink in front of me and I want 5. Now it's like, that's fine.
Wow.
Or,
Impressive.
it'd be a great bottle of wine. I'm like, nah, club soda.
Are you an advocate for more people being on GLP-1s in general?
No.
I am an advocate for GLP-1s as assist to individuals who are struggling with substance abuse, who are struggling with overeating, who want to lose weight, whether it's because they feel like they're overweight. I mean, I don't want people who are like a size 0 on GLP-1s. Like, don't get me
I
wrong.
mean,
I'm not promoting like more people like becoming anorexic. I am promoting though that we need to change the narrative that it's a crutch for people who are weak to the same way we think about diabetic being on insulin. Like some people's bodies don't work the way that they need to work, and some people need help. And I think it's a great innovation, and it works for a lot of people.
and it's also likely very hormonal. Like there's hormonal interactions that you can't solve by doing one thing differently. Like you can't just be like, oh, I stopped eating gummy bears every night. What's going on? Hold it where? Down here. Oh, sorry, everyone. It's a good thing someone is telling us what to do. Because it's certainly not me. Thanks, Michael. And that's like I can't just like stop eating gummy bears every night. I have to do much more than that to adjust my hormones that I don't even understand.
My big thing with individuals on GLP-1 for weight loss is that it needs to be paired with nutritional counseling. That was the difference for me. I was like, oh, I'm going to do this. It's going to curb my appetite in a way that was like astounding. And it's allowed me to say, I'm going to change my diet entirely. I'm not going to eat pizza every night. I'm not going to eat filet mignon. I'm going to eat like lentils and cucumbers, which sounds really boring, but I like found a way to love it. And through that like complete loss of food noise, I was able to drive positive change. And now like I eat very differently.
Well, and then the other thing, which is so I think the pill mill side is just disgusting and absolutely the government should do everything they can do on an enforcement side to stop it. I think it's really dangerous and really
Sounds
horrible.
like just the big manufacturers
No,
are doing a lot about it.
Well, they have to, but the government also needs to support and say, no, you can't, make up this like now fake story about shortages and give it to anybody who needs it for any or wants it for any particular reason. The other thing is, there are obviously some negative side effects, but they can certainly be mitigated by actually having someone have a doctor's appointment and be screened for those things. And that's my thing is like, once it's available on the street, basically, then you have people, maybe you have eating disorders, first and foremost, very dangerous for eating disorders, very dangerous to have that out there in the world. Really concerning. Was just talking to a colleague about this and how the risk of exacerbating eating disorders. And then also all of these like serious and very rare side effects. Those are things that could be screened by a medical doctor.
100%. Like this is not something that I think you should like go on to an
yourself.
Instagram ad and DIY. Like you need to
Like mushroom chocolates, Kat?
Oh, I mean, like,
I've never ordered
lot.
chocolates, to be clear. I
From
just
a-
get a lot of
from an Instagram ad.
I just get a lot of Instagram ads about them. And I think, No, so like here's my thing.
Is that because you forage your own?
She does.
Well, I do have I do
I'm
forage a lot of mushrooms, and most of my Instagram is me posing with a mushroom I found.
That's true.
So yeah, it's like the fish
It's
trophy
true.
for dudes. No, but like that's so the GLP-1 thing. Like I think people should have medicine if they need it. Like absolutely. I just like it's kind of filthy if you look out in the market about how it's being advertised and pushed.
Yeah, oh, I agree. I agree. But you know what?
How is it
like-
any different than Humira being everywhere?
But don't hate the player, hate the game.
But
It is the established launch playbook for a branded
Yeah, it is. It is.
high cost
Well,
drug.
no, but it's a lot different. Humira is like you have to have like a real like medical condition to get that. And
Do
they're
you?
compounding that on the
Do
streets,
you?
Really, and,
You-
like, pushing
you-
it to the
Do
market.
you?
You do.
It's expanded a lot.
It's expanded a lot.
more than you would imagine. Like to be clear, Humira is life saving for a
Oh, yeah,
number
100%.
of people, but also the expansion of Humira is a drug company motivated expansion versus a condition motivated expansion.
I mean, like let's
For
call it what it is. Healthcare is a business. It's a
Yes.
business for pharma. It's a business for not-for-profit healthcare. It's a business for payers. It's a business for brokers. Like this is a for-profit industry with a lot of not-for-profit assets running around it, but we're a for-profit enterprise.
That's
It is.
that's actually what you just said. Is I want to say it again. It's a for-profit industry with a lot of not-for-profit assets running around. That's a no. That like genuinely, that's a very
We should write
like
that
that's
down.
a legit thing. Like I agree with you.
And I don't. That's
Sponsor us, we'll
Yeah.
put that quote on our
Yeah.
website in your face.
yeah.
Oh,
The-
All
the-
$30.
with
all
Mudang
$30.
biting you.
Mudang biting me. Love Mudang. We need more Mudang in healthcare.
Yeah,
I renamed one of my dogs, obviously Florence, because she's the crazy one. Florence is now Mudang.
Well,
My dog
also,
bites a lot, too.
Mudang is going to grow up and be
I
less
know.
cute. Like that's the
and
bummer.
eat somebody probably.
I mean, children grow up and they're less cute.
I know.
Adults are way less cute than
It's
children.
Like, it's like a fleeting thing. Like
Adult
we have
dogs-
Mudang for a short time.
Yeah. But you know what? There will be another Mudang. There's Cookies the seal. There's Pesto the penguin. There's some like aardvark that was just born that's like painfully cute. I saw an Instagram video of a groundhog or a prairie dog or something. It's so cute.
They're really cute.
Babies are just cute.
Babies are cute. Babies are cute.
Okay. Well.
Yeah,
Okay.
okay.
AI. What do you think? What do you think? AI here.
How
what-
many
what do you
AI
think?
things have you seen today? And is the answer 1 trillion?
Can we define AI? Is it artificial?
They don't
Yes,
know.
please.
Is it artificial intelligence? Is it assistive intelligence? Is it anonymous individual?
Anonymous.
I mean, look at the Amazon.
Automating.
Is it?
Oh my god.
Is
I
it?
love this conversation. What is it? Tell us.
I think the transformative impact of
Is it a
AI,
person in a call center far away
That's
who's,
anonymous
who's
individual.
filling the?
I mean, that's the Amazon Go case. Amazon Go, there was no AI in those stores. It was 1,000 people in India.
Love
Oh,
it.
we're being told to wrap it up. Okay, here's.
No,
I'm
we need to
I'm
know.
bullish on AI. I'm bullish on AI
Right.
because I think that healthcare needs to transform and eliminate waste. As an assistive set of technologies, it can do that. Generative is powerful. It can be co-pilots. I want EHRs to fade to the background in AI, and there's commotion. AI can help with that. We need something to be positive and excited about. And I'm going to be positive and excited about AI. There's too much skepticism and cynicism. As we had a skeptical, cynical, I'm going to choose to be bullish and positive about the impact of AI.
I don't know.
What are you positive about?
Going home on
Mudang.
Tuesday.
You know what I'm positive about? I'm
Mudang,
positive-
Mudang,
I'm positive about AI technologies and other efficiency technologies supporting services on the ground, clinical services.
I think that healthcare is as a for-profit enterprise, we suck at consumerism. We don't have enough resources. We have a clinician shortage
I
that
don't
is like
think patients are consumers.
they are consumers.
I think
These-
they're different things.
They are.
We can fight about this all
we can fight
day.
about this all day. On our
I'm
next
looking forward to it.
segment, we're gonna go in a cage match fight about our patient consumers. We need to treat patients like consumers. We need to consider preferences. We need to be much more consumer driven about the delivery of
That's
healthcare.
like system change, though. Like we need system change for patients. To
He's
be
for system change. He's
I-
for system
Okay,
change.
well, we can do that.
He's ready.
But like that's like saying we need to change our food system.
You know, like
Well,
the Democrats are running on this like we're not going to go back. We can go forward. I had breakfast with Jonathan Bush this morning. Love
Love that guy.
that guy.
Is he voting for Kamala?
And he's going to be the governor of Maine. He told me it would be a great business environment for our incentive.
He would be the governor of Maine.
I want him to be the governor of Maine. I am.
I would not be opposed. Like
This message is brought to you by Michael Musi. There's no paid advertising, but I like Jonathan
Jonathan
Bush.
Bush for the governor of Maine.
We love him.
We love JB.
I like him a lot.
There's Faye. There's his wife right over there. Hi, Faye. Yeah, no. So I think we need where were we? Oh, we need to be bullish on AI.
We were starting
and
Jonathan Bush's
Optimistic.
campaign.
And we need to be optimists, and we need to be a more consumer-driven system. The experience of being a patient in the U.S. healthcare system, unless you have like a concierge doc, sucks.
Yeah, it does. It does really suck. I also think like we need the benefits of being consumer. I was just saying earlier, like people with employer-sponsored insurance, they have deductibles that are $6,000, $12,000, whatever, and so they're acting like cash pay patients without the benefits of being cash pay. Without, I can negotiate with you. And say that's too much for me. I don't want to pay that. Like, give me your 50% discount. Can't do that.
Okay, so like my last story, then Melissa kicked me off. I'm a concierge doctor. I'm not too proud to admit that. I needed to talk to my doctor yesterday. I texted him at 9:30 in the morning, and I was like, I've got a flight later today. I need to talk to you. I talked to him. He's like, you need to see a doctor. I'm like, I'm not going to the ER on a Sunday. He goes, don't worry, I'll come to your house. I don't think that all of healthcare needs to be that way, but we need that consumerism. I pay for that consumerism because I'm fortunate, but everyone deserves that experience, and AI can help bridge where we are to where we need to be.
Great. Okay, so when you come back for your sponsored session, we'll talk more about consumerism in healthcare.
Yeah, we'll talk about
All right. Great.
Adios. I can't wait to see you at a happy hour.
See you really soon.
which one?
I sent
all
you
of
my agenda. I sent you my coordinates. I can't tell people where I'm going to be.
All right.
I texted it to you.
Great.
We were talking about caviar towers.
All right.
Oh, okay.
Krissa
Oh my gosh.
and our final guest.
Oh my gosh.
Hello. It is so great to see you in
good to
person.
see you.
How's it
Hi.
going? Lovely. Sorry, we are sharing one mic.
Okay.
It's very
No
busy.
worries. This is part of the show.
Okay.
Technical difficulties. So introduce yourself.
Of course. Well, hi, everyone. I'm Krissa McFarland, the founder and CEO of Patientory. We're based in sunny Atlanta, Georgia,
Yay.
Hotlanta. And Patientory is a digital health data wallet. So we're helping consumers to aggregate, securely store their health information, and monetize their data for clinical research or healthy goals.
Similar vibes. Similar vibes.
So many vibes.
Yeah.
We love monetizing.
I love monetizing things.
So that's great. Okay. So yeah, like tell us what that actually means.
Yes. So I don't think we've ever covered this, but we are a Web3 based company. We, raised a lot of eyes when we created a cryptocurrency.
Yeah.
I
remember.
Yeah.
Remember.
Yes.
We're Aquarius. So I'm in.
Yeah. So we pretty much have built a national blockchain network. We're part of TEFCA. I'm on the Advisory Council for Care Equality. So we're pretty much a patient access driven health information exchange, and we built a wallet that can help to store that data for patients.
Yeah. Very cool.
What do you? So I'm really interested in getting together a coalition, a group of organizations, entities who are really passionate about making individual access actually happen. Like it's been stymied by the, it's been stymied. The whole promise to us was like, 20% to cures, we're going to base it on patient access. So like
that was the goal.
that was the goal. So like talk about what you're doing in that front. And like, do you want to join my yet not to be named coalition?
I am all for it. Sign me up. I don't know the name, but sign me up.
We're going to work on the name.
Yeah, so like, what do you think about all this bullshit about like participants on the networks don't have to respond to individual access queries? Yeah. Like, is that bullshit?
That is BS.
Oh.
Yeah.
See?
So too.
Okay.
Yeah.
Like, why isn't it happening?
Because people aren't trustworthy. You want to know what? People like to take the easy way out. People, they don't like hard things.
Yeah.
And that's the thing about it. Like, there isn't really a framework where we're working towards it, but there isn't really a clear, direct framework that they can go to. So when there's no framework, people do.
They're like, how will I authenticate this? How will I know? What if I'm giving the data away? And you're like, well, it's my data, so give it to me.
Exactly.
So, well, how did you get into this? Because this is like,
Long
like the web
story.
crypto, the-
Yes. Long story. So prior to this, I was managing a telemedicine company. So I'll start before that. I started out as a microbiome researcher. Decided to go to business school. I did a semester of med school and was like, okay, I don't think I want to spend my life doing this because I really wanted to have impact. I ended up going to business school, found my way to healthcare consultant, did a lot of pharma operations mid-tier, EMR implementation. So we would go in and implement electronic medical records. Found my way, into this really cool telemed startup in 2014. They're pretty early out of Soho in New York City. And I just saw how bad it was in getting data. We had to three-way call the patients. to get them to sign off with
Wow.
their provider, to give our teledocs access to the data. It was like a nightmare. I had my father being misdiagnosed,
Wow.
because he had moved from New York to Georgia. They didn't have anything. So I just
Wow.
saw just how complex it was. And, with me, loving a challenge, I was like, hey, what can I do about this? And decided to start Patient Worry.
It's always interesting when people who are like not in the center of it, like people who are smart and active and engaged are like, wait a minute, why can't I access the data? Or why, like, when people come in from like not being in data exchange generally, and they come in and say, but wait, why is this so bad?
Exactly. And that was like, I was in healthcare, but not really
Yeah.
directly connected
You're like,
to information exchange. But I'm like, why?
That's what everybody says. But so talk to us about the Web3 thing. Is that primarily because of the trust issue? It's a layer of privacy.
Exactly. So getting into it, the researcher I am, I had a friend that was building, who actually was on the early team, help with the white paper for Ethereum. And I was tracking the Bitcoin stuff and did a workshop. It was actually through an accelerator I did when I launched Patient Worry. And they talked about blockchain, and I was like, well, I know someone that's doing that, and he's building like the storage system. Why not? And it all made sense.
It's like the actual only legitimate use case for blockchain in healthcare that I can think of is that trust layer, right? There was a huge, obviously before the current very AI hype, there was a very blockchain hype that didn't play out in terms of like what actually faces patients and people in clinical care. There's some back end applications and things like that, but the front facing stuff seems to have all kind of fallen away, except for the legitimate use case.
Like
Yeah.
patient access.
Yeah.
And it's like it's all rebranded now into like Web3.
Yeah.
Sure.
So it's
Whatever.
like, it's
Sure.
no longer
Sure.
blockchain, It's all Web3.
Fine. It's a good Whatever.
It's like,
Rebrand it. It's fine.
It's just a rebrand.
Oh, Kat is being mean to me. Loyal watchers. No, but it makes sense. It's really cool. So what are you here at Health to do?
Yeah, so we're looking at partnerships at Health. So as you say, like we're giving consumers and patients their health data utility. We actually this year launched into GLP-1, which is like all the hot topics. It's like we're aggregating the data. How are we using this to provide recommendations for people to actually improve their health? Right. So part of that is
Tell us how that works.
Yeah, so we have the wallet now. So it's like we can trigger, let's say someone has a BMI over 25. We actually partner with a company that provides telehealth services that would write a prescription for like GLP-1. So we're, partnered directly with the manufacturers. We, support all the branded from Ozempic, Wegovy to semaglutides, tirzepatides, which is, hard to come by these days, especially for people that can't afford it. But it's on a short list. It's on the FDA short list.
I think it's getting off the shortage list.
Yeah.
Like it's coming off now. Yeah. Which will change the entire sort of story. Yeah.
Yes. And that's what we want to meet here. So we're having conversations with the compound pharmacy.
Oh, interesting. Well, we almost had one on the show. He was here. He's around here. We'll point him out to
There's
you.
someone here.
Sean Norian. Yeah.
So tell us about the monetization.
Yes. So there's monetization right now. So we're pretty much have a care plan that's AI assisted. We're getting people the ability to continue to stay motivated around their health. So that's anything from connecting your wearable devices, Apple Watch, Fitbit, and meeting those goals. So you walk, we're at Health. You walk
You're gonna walk
5,000 steps.
You will walk your steps right
Why
here.
not earn crypto for that? People already do that
You
today.
could be earning more crypto. That's a big deal.
I do like crypto.
You do like
Send crypto to Kat.
I do actually.
I feel like probably yes. Send it to Kat.
I will accept it. She'll accept it.
Yeah, so we're looking to grow that awareness around people being able to use their data that they already create today and monetize that.
Nice.
Awesome. So what do you think of health in general?
Health is, it's a great place for us to network. It is a big sea. It's a mass of people.
Yeah.
I think the challenge is identifying like who do I need to meet, who do I not need to meet. Yeah.
How big's your team?
So we're about 8 people. We're still pretty nimble, as we like to call it. We like to stay lean, especially in this niche state that we're in. So that's part of what we're here to continue to grow, like partnerships, connect with investors, etc.
Another Georgia health tech
Hey, I love
innovator.
Georgia. Like we're trying to make Georgia cool. I mean,
Oh, we just opened up the science center. We have like a new science center there. So
I will say
be the thing.
we did meet the folks from the Nashville Healthcare Council, and they seemed very competitive. Like they were like,
they're
we are.
really competitive. Well, they have the whole healthcare ecosystem. Everyone is, it's about the collaboration.
The Godfather, they have Bill Frist.
We don't.
Yeah.
We don't have.
We don't have one. We need someone.
Godfather of
Delta. It's just Delta.
I love that guy.
Just Delta. We have someone else. We have to have
Like Delta could fund the health.
Dr. Blake. Yeah. Who are we have the share care guys.
Oh, yeah, the share care people.
Doesn't sound quite as impressive as Nashville. Okay, Nashville folks, you're winning right now. Shout out to Liddy, who was very, very great person to sit next to at dinner.
I mean, but we are international hub. I mean, the airport,
I
the
know.
busiest airport in the world.
Yeah.
Why not make it cool for health? Right?
Exactly. I mean, again, I think Delta should fund. They probably do fund some. They should do more. Delta, do more.
Yeah. Do more
Be
about
great.
health. So that's an opportunity there.
Definitely.
Awesome.
Agreed. Well, what else? What else we got going on? Is this it? What? Yep. All right.
We're reaching the end of our time. Thank you so much for
Thanks,
coming on the
guys.
show,
Thank you for
Krista.
coming on.
Nice to meet you finally.
Catching you around.
Yeah, awesome.
All right.
All right, we are gonna wrap it up in a few minutes. So, any other final, Kat McCabbett? We're here at Health again. We have a little fake wall here.
We'll be in a new location later. Melissa says she hates this location.
Oh, really? I like it.
You can't hear it keep dropping.
Oh,
So many problems.
oh no. Sorry, everyone. As you know, we have no budget for the show, so we're doing our
I
best.
will find another location.
Great, fantastic.
It's fine.
We're gonna be at the love sign. It's all good.
Yeah.
Yeah.
I'm not worried.
Okay,
Okay.
Melissa,
I'll watch.
cut the feed. See you all later on.
See you too.